So picture this. You're standing at the bedside of a patient. They're sitting up, they're talking to you, and their skin color looks pretty much normal.
Right.
And the monitor above their head is flashing this perfectly textbook blood pressure, like 120 over 80. By every visible metric, every standard alarm bell we rely on, this person is completely stable.
But they're actually not.
Exactly. Beneath the surface, their cardiovascular system is quietly, desperately pulling, like every emergency lever it has. They are maybe 15 minutes away from a complete hemodynamic collapse.
And their own body is actively masking the crisis. It really is the ultimate invisible emergency.
It's terrifying.
It is, because when the human body starts losing significant fluid, it doesn't just instantly wave a white flag.
Yeah.
It compensates. It hides the deficit so well that if a clinician doesn't know exactly what subtle physiological tells to look for, they'll walk right past a patient who is actively falling off a cliff.
And that terrifying clinical blind spot is our mission for this deep dive. Today, we are reading Fluid Loss Before the Crash. We're taking this stack of nursing textbooks, historical medical case studies, and modern clinical guidelines to really understand the hidden mechanics of fluid balance.
We want to figure out how the body loses fluid, right?
Mm-hmm.
And the elaborate biological smoke and mirrors it uses to hide that loss.
Yeah, and most importantly, how you can spot the crisis before the vital signs finally crater. So, okay, let's unpack this. We have to start with the vocabulary, because right out of the gate, the terms we use casually every day are actually fiercely debated in the clinical world.
Oh, heavily debated.
Specifically, the line between dehydration and volume depletion.
Yeah, the terminology is kind of a mess, but the physiology behind it is incredibly distinct. So, strictly speaking, true dehydration refers to a loss of pure, free water.
Like sweating in a desert.
Exactly. Imagine you're sweating intensely out in the sun without drinking anything. You're losing water, but your body is leaving the sodium behind. And because the water leaves and the salt stays, the concentration of sodium in your blood spikes.
Which triggers hypernatremia.
Right, high sodium. Now, volume depletion, on the other hand, is an entirely different beast. Also known as hypovolemia, this is what we call an isotonic loss.
Meaning the patient is losing both water and sodium at the same time, right, in proportional amounts.
That's the crucial difference. If someone suffers a severe hemorrhage or they have, prolonged vomiting or diarrhea, they're losing the entire fluid package. Water, sodium, the works.
So if we draw blood from that patient in the ER, their serum osmolality, which is the clinical measurement of how concentrated particles like sodium are in the blood, it might look totally normal.
Totally normal. They aren't technically dehydrated by the strict medical definition. Even if they're down like 3 liters of total fluid, they are volume depleted.
Yet, if you look at the charting on almost any med-surg floor right now, nurses and doctors alike are writing dehydration as this catch-all umbrella term for both scenarios.
Yeah, they use it interchangeably all the time.
And it's not for a lack of trying by major institutions to fix it. I saw in the sources that the U.S. National Institute on Aging held a major consensus workshop in 2004 specifically to force the medical community to separate these two terms.
Because they were terrified. Using dehydration for everything was leading clinicians to give pure free water to patients who desperately needed sodium-rich IV fluids.
Wow, yeah. And then the European Society for Clinical Nutrition and Metabolism tried again in 2015.
Mm-hmm.
They tried to rebrand the concepts as water loss dehydration versus salt and water loss dehydration.
Which is quite a mouthful.
Yeah.
And those institutional efforts largely failed to change bedside habits. Because in a high-stakes hospital environment, nurses just need an operational shorthand.
So for anyone listening to this deep dive, what's the working definition that actually matters today?
The one that dictates patient care is basically this: dehydration, in the colloquial clinical sense, happens whenever fluid output exceeds intake for long enough to cause measurable physiological compromise.
Okay, and to understand what that compromise actually looks like inside us, we have to look at the math of the human body.
The math is fascinating here.
We've all heard the statistic that an adult is roughly 60% water, but that water isn't just a giant unorganized reservoir sloshing around in there.
No, not at all. It is rigidly locked into specific physiological compartments. And this compartmentalization is where the unseen crisis actually happens.
Right, because 2/3 of that water is intracellular. It's trapped inside your actual cells.
And only 1/3 is extracellular, living in your blood plasma and the spaces between your tissues. So the type of fluid you lose determines which compartment gets drained first.
Going back to our definitions.
Exactly. If you suffer an isotonic loss, like bleeding, You drain that extracellular space directly. That immediately threatens your circulating blood volume.
But if you lose free water like true dehydration, the physics completely change.
They really do, because of the laws of osmosis. When you lose pure water, your blood becomes highly concentrated with sodium. And nature, well, nature hates an imbalance.
It wants to equalize everything.
Right, so to dilute that increasingly salty blood, the body forcefully pulls water across the cell membranes. It drags fluid out of the intercellular compartment and into the blood.
You are physically draining the fluid from inside your own cells.
Yes. This is the underlying mechanism of why severe hypernatremic dehydration causes profound confusion, delirium, and eventually seizures. The osmotic gradient is actively shrinking the patient's brain cells.
Oh, wow. Visualizing the brain cells physically shrinking makes the stakes incredibly clear. It actually brings up an analogy I was piecing together from the source material.
Oh, what's the analogy?
Well, the body's biological response to sudden fluid loss operates remarkably like a massive corporation facing an unexpected bankruptcy.
Oh, I like that.
When the revenue stops flowing, the company doesn't just instantly shutter its doors, right? It goes into an aggressive, calculated survival mode.
Right. It cuts all the peripheral, frivolous spending to protect the core assets.
Exactly. And in human anatomy, the core assets, like the CEOs of the company, are the brain and the heart. The body will sacrifice almost anything else to maintain the blood pressure necessary to keep oxygen flowing to those two organs.
And it achieves this through a pretty brilliant two-tiered compensation sequence.
Yep.
The first step is instantaneous. The sympathetic nervous system fires.
The classic fight-or-flight response. The body floods with adrenaline, driving the heart rate up.
Tachycardia again.
And it slams the peripheral blood vessels shut to keep the pressure centralized.
Which is exactly why a patient in the early stages of volume depletion will often have skin that looks pale or mottled, and their hands and feet will feel cold to the touch.
Because the body has cut the budget to the skin.
Precisely. But because of this intense peripheral clamping, if you put a standard blood pressure cuff on their arm, the monitor reads normal.
The sympathetic nervous system is literally creating a mechanical illusion of stability.
And then the second tier of the survival mechanism kicks in to reinforce that illusion, the RAAS cascade.
The renin-angiotensin-aldosterone system.
That's the one. Within minutes to hours of sensing a drop in fluid volume, the kidneys release the enzyme renin, triggering this complex hormonal cascade. The ultimate goal of RAAS is to act like a biological dam.
It floods the system with aldosterone, right?
Yes. Instructing the kidneys to absolutely halt the excretion of sodium and water, it hoards every available drop of fluid to desperately maintain that central circulating volume.
And this is the crux of why checking blood pressure can be so dangerous if it's your only metric. The body fights so aggressively with vasoconstriction and the RAAS cascade that a sudden drop in blood pressure is actually a late-stage failure.
By the time that biological dam breaks and the patient becomes hypotensive, they've often already lost 15 to 30% of their total blood volume.
Which is a massive amount of blood.
It is. Relying on hypotension to diagnose volume depletion guarantees that you're already behind the curve. The physiological cliff is incredibly steep at that point.
Which necessitates a way to look past the body's smoke and mirrors. Our sources emphasize a low-tech, bedside assessment called orthostatic vital signs.
Orthostatics are brilliant. They use gravity to break the body's compensation mechanism.
Instead of taking vitals while the patient is lying flat in bed where the heart doesn't have to work very hard, you take their pulse and blood pressure, and then you have them physically stand up.
And standing forces a massive, instantaneous shift of blood down into the legs. If the patient has a normal fluid volume, their vascular system easily squeezes to push that blood back up to the brain.
But if they're secretly hiding a 20% fluid deficit,
then that sudden gravitational demand totally overwhelms their maxed out compensation system. If you see their pulse suddenly jump by 30 beats per minute, or their systolic blood pressure plummet by 20 millimeters of mercury just from standing.
You've caught the invisible crisis. You force the body to reveal its true deficit.
It's a masterful clinical tool. But, when you look at how beautifully complex the RAAS cascade and osmotic gradients are, it raises a fascinating historical question.
How did early physicians map out this invisible terrain of volume depletion centuries before we had the technology to measure serum osmolality or identify hormones like aldosterone?
Exactly. It's wild to think about.
Well, to answer that, the sources take us back to one of the most terrifying medical crises of the 19th century, the 1832 London cholera epidemic.
Cholera is a brutal disease. It's characterized by the sudden onset of rice water diarrhea, which drains massive, lethal amounts of fluid and electrolytes from the body in just a matter of hours.
And the mortality rate was staggering because the standard medical paradigm at the time was still heavily influenced by miasma theory.
The idea that bad air caused disease.
Right. Or they believed in humoral imbalances treated with bloodletting, which obviously only accelerated a cholera patient's death.
Absolutely. But during this 1832 outbreak, a young physician named William Brooke O'Shaughnessy took a completely different approach. He started performing primitive chemical analyses on the blood of cholera victims.
O'Shaughnessy discovered that the patients weren't just succumbing to a mysterious airborne poison. His chemistry showed that their blood was physically drained of a large proportion of its water and very specific neutral saline principles.
He fundamentally redefined cholera, taking it from a mystical affliction to a quantifiable mechanical loss of fluid and salt.
And that chemical revelation caught the attention of another physician, Thomas Letta. Letta realized that if the disease was mechanically removing salt and water from the blood, the cure must be mechanically putting it back.
Directly into the veins. He found a 44-year-old woman who was in the absolute terminal stages of cholera. She was pulseless, her extremities were blue, and she was entirely unresponsive.
And Letta injected a primitive heated saline solution directly into her basilic vein.
It is hard to overstate how radical this was. The concept of intravenous fluid resuscitation simply did not exist.
And the result of that first infusion was miraculous. Within 30 minutes of the saline entering her bloodstream, her pulse returned, her skin regained color, and she sat up and began speaking clearly.
It was the dawn of rational fluid resuscitation. Now, the ending of Lada's specific case was tragic.
Right. They didn't understand maintenance fluids yet.
Exactly. The medical establishment didn't understand continuous fluids. They stopped the infusion when she looked better, the cholera continued to drain her volume, and she died later that day. But the conceptual breakthrough had been made.
And if we fast forward 100 years to the 1930s, we see the systematization of that breakthrough. At Boston Children's Hospital, a pediatrician named James Gamble started rigidly measuring the exact chemical components lost in infants suffering from severe diarrhea.
He created these incredibly detailed visual charts, which became famous as Gamblegrams.
To map out the precise deficits of sodium, potassium, and chloride.
Yes, and Gamble's visual maps allowed the medical field to finally categorize dehydration into the three primary types we still reference today: isotonic, hypotonic, and hypertonic.
He provided the framework to tailor Thalavy fluids to the specific chemical deficit of the patient rather than just guessing.
Which was a game changer.
I do want to pose a question here, though. We're talking about Gamble doing this in the 1930s. Today, modern medicine has access to incredibly sophisticated laboratory testing. We can draw blood and measure a patient's exact serum osmolality down to the individual milliosmol.
Very true.
So why do modern nursing guidelines still heavily emphasize low-tech bedside proxies? Why are nurses pinching a fingernail to check capillary refill or making a patient stand up for orthostatic vitals instead of just waiting for the high-resolution lab chemistry to tell them exactly what is wrong?
That is a critical question, and it comes down to the velocity of the physiological crash.
The speed of it.
Yes. As we discussed earlier, the compensatory mechanisms hide the deficit until the very last moment. When a patient finally begins to decompensate, the cliff is incredibly steep.
So there's no time.
Exactly. If a clinician draws blood and sends it to the lab, the turnaround time for those results might be 45 minutes to an hour. In the context of a failing cardiovascular system, an hour is an eternity.
So bedside proxies like capillary refill and orthostatics exist because the frontline clinician literally cannot afford to wait for a lab result.
They need a real-time signal to intervene before the hypotensive crash occurs.
Which means the intervention itself has to be both immediate and chemically precise. And this brings us to one of the most counterintuitive themes in our source material.
The realization that in certain crises, giving a severely depleted patient a glass of plain water is the absolute worst thing you can do.
Yes. This is perfectly illustrated by the discovery of oral rehydration therapy, or ORT, in Dhaka during the late 1960s.
Researchers were trying to combat cholera in regions where widespread IV fluid resuscitation was logistically impossible.
Right. And they were dealing with a disease that completely paralyzes the gut's normal ability to absorb water. But they discovered that one specific microscopic gateway in the intestinal wall remains functional, even during severe cholera.
The sodium-glucose link transporter, or SGLT1.
I love how the mechanisms work here. The SGLT1 acts like a biological dual key security system on a bank vault.
That's a great way to picture it.
If you give a call or a patient plain water, the vault stays locked and the water just passes straight through them as diarrhea. If you give them plain sodium, it stays locked.
But if you provide a highly specific ratio of water, sodium, and glucose,
The glucose and the sodium act as two keys turning simultaneously. It physically forces the transporter open, actively dragging the water across the intestinal lumen and into the bloodstream.
it is an elegant hack of human biology.
Huh.
By utilizing that transporter, clinicians could rapidly rehydrate dying patients without a single IV needle.
The Lancet famously referred to ORT as potentially the most important medical advance of the 20th century because it perfectly leveraged the body's own precise cellular mechanisms to save tens of millions of lives.
It really is an incredible story.
But here's where it gets really interesting. We have this massive triumph in the 1960s proving that fluid balance is a delicate mechanism of precise ratios.
Right.
Let's contrast that deep understanding of osmolality with the hydration culture of the 2002 Boston Marathon.
Oh, man. It is a devastating juxtaposition. For decades, the endurance sports community aggressively pushed a blanket hydration narrative.
Drink before you're thirsty, right?
Yeah, drink before you're thirsty and drink as much as possible to avoid collapsing. They basically treated the human body like a simple reservoir that just needed topping off.
Which, if you are a runner listening to this, you're probably mentally auditing every hydration station you've ever stopped at right now.
I know I am.
Because in 2005, a landmark study in the New England Journal of Medicine by Christopher Ullman analyzed the runners from that 2002 marathon. They discovered that a significant percentage of the finishers were suffering from hyponatremia.
Dangerously low blood sodium.
And tragically, this exact mechanism led to the death of a 28-year-old runner named Cynthia Lucero. She collapsed and died from water intoxication.
We have to look at the osmosis mechanism again and understand how drinking too much water becomes fatal. These runners were sweating out both water and massive amounts of sodium for hours.
But at every mile marker, they were replacing those losses with pure, free water.
Exactly. As they pumped liters of free water into their system, they drastically diluted the sodium concentration in their blood. Their serum osmolality plummeted.
Meanwhile, the fluid inside their brain cells maintained a higher normal osmolality.
And remember that nature hates an imbalance. The massive volume of free water in the blood violently rushed across the blood-brain barrier and into the brain cells to try and equalize the concentration.
So the brain cells physically swelled up with water. And because the brain is encased in a rigid, inflexible skull, that swelling quickly leads to catastrophic pressure, coma, and brainstem herniation.
It's horrific. It forced an entirely new paradigm in sports medicine. Fluid replacement is never just about dumping volume into the body. It's entirely dependent on the ratio of water to solute.
And that precise lesson wasn't just limited to marathon runners. The exact same foundational misunderstanding of free water caused a quiet, decades-long crisis in pediatric hospital care.
Up until very recently, the standard medical practice across the globe was to place hospitalized children on hypotonic 5E fluids.
Fluids that have a lower osmolality, meaning more free water and less sodium than normal human blood.
Right. The rationale was simple. Children are sick, they're insensible fluid losers, they need hydration.
Yeah.
But in 2018, the American Academy of Pediatrics issued a massive guideline change, completely reversing decades of standard practice.
What drove that reversal? Like, what was the physiological mechanism they were missing?
They realized they were fundamentally ignoring how the stress of illness alters a child's hormones. When a child is sick, whether from pneumonia, surgery, or an infection, their body naturally ramps up the secretion of antidiuretic hormone, or ADH.
And ADH is basically a chemical mandate sent directly to the kidneys telling them, do not, under any circumstances, pee out free water. Hoard it.
Exactly. So the children's bodies were biologically primed to retain water. When doctors then aggressively pumped their veins full of hypotonic 5E fluids, the ADH trapped all that excess free water inside their systems.
It created the exact same mechanism as the marathon runners.
Yes.
The free water diluted their blood, and the osmotic gradient forced the water into their brain cells, leading to fatal hospital-acquired hyponatremia.
Once the mechanism was understood, the clinical guidelines had to instantly pivot to mandate isotonic fluids as the new default, matching the AVI chemistry to the body's stressed physiological state.
It's a really sobering reminder that applying overly simplistic rules to a complex physiological system can be actively dangerous.
Which serves as the perfect transition into dismantling the pervasive, everyday hydration myths that the general public still largely believes.
Okay, let's start with the most entrenched myth of all. The 8-ounce glasses of water a day rule. We hear it everywhere, from fitness influencers to health blogs.
Oh, the 8x8 rule is a fascinating case study in how scientific data gets cherry-picked and distorted over time. The origin actually traces back to a 1945 recommendation of the U.S. Food and Nutrition Board.
Which stated that adults require about 2.5 liters of water daily.
But the people quoting that number conveniently stopped reading halfway through the paragraph. The very next sentence of that 1945 report explicitly stated that the vast majority of that 2.5 liters is already contained in the prepared foods we eat every single day.
You extract significant water from apples, pasta, soups, vegetables.
Exactly. In 2002, physiologist Heinz Walton published a comprehensive review that completely dismantled the 8x8 rule as a biological requirement for healthy adults.
Because applying a rigid mathematical water quota ignores the massive variables of human physiology.
Right. A 200-pound construction worker in a humid climate has vastly different osmolality demands than a 120-pound office worker in a climate-controlled building.
So if 8 glasses is a myth, what do the clinical thresholds for actual danger look like?
To give it scale, let's look at an average 70-kilogram adult. A fluid loss of roughly 2 to 3.5 liters triggers the body's moderate warning systems.
Dry mucous membranes, thirst.
Yes, and their kidneys will concentrate their urine to conserve volume. The brain's osmoreceptors will trigger a strong sensation of thirst. But if that same adult drops 7 liters, which represents roughly 10% of their total body fluid, the compensatory mechanisms begin to fail.
This is a profound medical emergency characterized by lethargy, sunken eyes, virtually zero urine output, and in severe pediatric cases, the physical sinking of the fontanelles on an infant's skull.
It's severe.
Reaching that 10% threshold is catastrophic, and our sources highlight that one specific demographic is horrifyingly vulnerable to silently crossing that line: the elderly.
Dehydration is one of the leading causes of preventable hospitalization in older adults.
But I always assumed this was largely a behavioral issue. You figure older folks simply forget to drink, or they deliberately restrict their fluids to avoid having to navigate a difficult trip to the bathroom in the middle of the night.
Well, the behavioral and mobility barriers are absolutely real. Fear of incontinence drives a lot of voluntary fluid restriction, but the true danger is rooted in the degradation of their biological alarm systems.
What do you mean?
If you look at a standard first aid manual, it tells you to look for a patient complaining of thirst. But thirst is governed by osmoreceptors in the brain sensors that detect when the blood is getting too concentrated. As we age, those osmoreceptors physically lose their sensitivity.
Wow, so an elderly patient's blood can reach dangerously hypernatremic levels, and their brain physically will not generate the conscious sensation of thirst.
The alarm wire has literally been cut.
That makes the standard assessment tools incredibly unreliable. What about the classic pinch test? You know, the skin trigger test where you pinch the skin on the back of someone's hand to see if it snaps back instantly?
Skin turgor is another physiological trap when assessing the elderly. The snapback of healthy skin relies entirely on a matrix of collagen and elastin in the subcutaneous tissue.
And as humans age, that elastic matrix naturally breaks down.
Entirely independent of how much water is in the body. If you perform a turgor test on a healthy, perfectly hydrated 85-year-old, their skin might remain tinted for several seconds.
So if a clinician relies on PERBR or thirst to assess an elderly patient, they'll miss the volume depletion entirely until the patient ends up in the ER with a confused mental state and a failing heart.
Which fundamentally changes how caregivers and clinicians have to approach this population. You can't just set an alarm to remind an elderly patient to drink if their kidneys can't concentrate urine effectively and their brain isn't sending thirst signals.
You have to rely on objective mechanical metrics.
Yes. You track daily weights on a scale to catch sudden, invisible fluid drops. And you meticulously check those orthostatic vital signs to see if the cardiovascular system is secretly straining against gravity.
So, what does this all mean for you as the listener? Let's synthesize the journey we've taken through the source material today. We started by dismantling our basic vocabulary, learning that a loss of free water shrinks the cells and spikes sodium.
While an isotonic volume depletion secretly drains the cardiovascular system, while the blood chemistry looks perfectly normal.
We uncovered the physiological deception of the body's survival mechanisms. We saw how the sympathetic nervous system and the RAAS cascade act as a biological dam, clamping down blood vessels.
And hiding a massive fluid deficit behind the illusion of a normal blood pressure reading.
We looked at the tragic consequences of misunderstanding osmolality. From the marathon runners drowning their own brain cells with pure free water, to the realization that sick children require precisely calibrated isotonic fluids to counteract their own stress hormones.
And this understanding isn't just an academic exercise. With global temperatures rising and heat waves driving unprecedented spikes in emergency room admissions, the ability to read fluid loss before the crash is a critical survival skill.
Whether it's a nurse on a chaotic med-surg floor catching an orthostatic pulse jump, or a caregiver recognizing the blunted physiological alarms of an elderly parent, spotting the unseen deficit is what prevents a silent slide into cardiovascular collapse.
It is a high-stakes game played entirely beneath the surface of the skin.
Which brings me to one final, truly mind-bending concept from the clinical guidelines to leave you with. It's a physiological paradox known as third spacing.
Oh, third spacing is wild.
I want you to imagine a patient lying in an ICU bed. If you look at them, they appear massively overloaded with fluid. Their legs are swollen, their arms are puffy, their tissues are stretched tight with severe edema.
To the naked eye, this person is drowning in excess water.
But if you look at the unseen mechanics, something completely different is happening. Normally, proteins in your blood, specifically albumin, exert what is called oncotic pressure. These proteins act like microscopic molecular sponges, physically holding the water inside your blood vessels so the heart can pump it.
But in states of severe illness, sepsis, or malnutrition, that sponge fails. The capillaries become dangerously leaky.
The fluid physically seeps out of the vascular system. It leaves the blood vessels entirely and becomes trapped in the interstitial tissues, the third space, where it is completely useless to the brain and the heart.
So you have a patient whose body is visibly swollen like a water balloon. But inside their actual circulatory system, their vessels are bone dry.
They are actively crashing from severe volume depletion, starting for circulating fluid while literally drowning in their own tissue edema. Can you trust your own eyes?
You really can't.
It leaves you with a profound realization about the human body. When the stakes are life and death, you can rarely trust the surface alarms. You have to understand the mechanisms hidden beneath. Because as we've learned today in the delicate mathematics of human physiology, what you see on the outside is almost never the whole story.